Thank you everyone for joining us today for our noon talk. Today we have the pleasure of welcoming Dr. Susannah Hickling to speak to us today. Susannah is one of our own. She's an MPU graduate. She did her bachelor's degree in physics at Western, then an MSc and PhD at the MPU. Following her grad program, she went to do a therapy residency at the Mayo Clinic in Rochester, Minnesota, and is now a radiotherapy physicist at CancerCare, Manitoba in Winnipeg. So with that, I'll hand it over to you, Susannah.
Awesome. Thanks, Pete, for the introduction. It's great to be back virtually at McGill. So today I'm going to talk about some work I did during my residency at Mayo, looking at the treatment of ocular sites with a gantry-based spot scanning proton system. To click the arrow, I guess. Okay, so a little bit of background about how I got involved in this project. So I participated in the MedPhys match and was lucky enough to be matched to the Mayo Clinic in Rochester, Minnesota. So an interesting kind of unique feature of that program is it's a 3-year program with an integrated research component. So it's a little bit different than some 3-year programs in the States where they have a dedicated year of research, either in the first, second, or third year. So it's up to the residents to manage their time along with assistance from their mentors to make sure they're nominally spending about 1/3 of their time on research and about 2/3 of their time on clinical rotations and training. So in terms of the research aspects, residents are assigned one major research project and also participate in a variety of smaller projects. So about a month before I started the program, the incoming residents were sent a list of potential projects, and we got to provide feedback about what main research project we would like to be involved in. And the one that kind of jumped out to me was this project looking at developing the infrastructure required to treat ocular sites on our Proton system. I wanted to take advantage of doing my residency in a major center in the US with Protons and kind of be involved in a project that had to do with that. So I was lucky enough to be assigned to that project where the primary goal was to develop the infrastructure required to treat ocular melanoma patients on the gantry-based spot scanning proton system at Mayo. So I want to acknowledge the Mayo Ocular Proton team. I was fortunate enough to work with a variety of colleagues from a number of different disciplines. From radiation oncology, we had radiation oncologists, medical physicists, therapists, as well as dosimetrists. We worked with ophthalmologists, and we had a very talented division of engineering team who had specialties in all areas to help contribute to this project. So massive multidisciplinary effort to get this going. So ocular melanoma is a rare but potentially fatal group of tumors. They're mostly commonly found in the uvea of the eye, which is the middle layer of the eye. This includes the iris, the ciliary body, as well as the choroid layer. Treatment options for ocular melanoma traditionally were enucleation, which is removal of the eye. Obviously, this isn't the most desirable treatment option. So in order to preserve the eye, radiation is considered the standard approach for treating these sites now. So radiation can be delivered to ocular sites using brachytherapy eye plaques, which are just sutured onto the eye with iodine-125 seeds. And those are left on the eye for several days to deliver radiation and then removed. So it's a low dose rate brachytherapy delivery technique. We can also use external beam to treat ocular melanoma, whether it be gamma knife, photon linear accelerators have been used, and protons are one of the main modalities, which is what I'm going to talk about today. So why is it desirable to use protons to treat ocular treatments? So protons are advantageous because they stop in tissue. So I'm sure most people are familiar with a figure like this, where we have a single energy proton beam coming in. We get this nice sharp Bragg peak, and then dose beyond the Bragg peak drops off to 0. We can build up many of these Bragg peaks or energies to get a spread out Bragg peak, so we can treat larger tumors. The advantage beyond the tumor or distally, we have very little / no dose, and just comparison, we have our traditional X-ray PDD, where we would have higher dose upstream of the target. So protons allow us to give a nice uniform dose in the target, as well as spare critical structures that are right adjacent or near the tumor. So some of the main indications for proton treatment compared to the other modalities, we tend to treat large anterior tumors with protons. We also treat small posterior tumors close to the optic disc or macula, as well as iris melanomas are typically done with protons. So conventionally, ocular proton treatments are done using a passive scattered beam and a dedicated horizontal beamline. So proton therapy for ocular tumors is not new. PSI, for example, in Switzerland, which is where this figure is from, has been treating ocular patients since the 80s, using a passively scattered beam and a dedicated horizontal beamline. So they have all the infrastructure required to treat ocular sites safely built into this beamline, and is only used to treat ocular sites. The patient is seated upright in a dedicated treatment chair, immobilized with a mask. And then there's a brass aperture. It's a little bit difficult to see in this picture, but it would be close to the patient's eye and milled out to be patient specific. So depending on the shape of that patient's particular tumor, the aperture would be designed for that purpose. So the typical workflow for ocular proton therapy, patients first undergo surgery to have radio-opaque markers inserted near the lesion. So an example is shown in this picture here. These are typical tantalum markers used. They would be sutured onto the eye by the ophthalmologist during surgery. They're about 2 millimeters in diameter and quite thin. And then also during surgery, some detailed measurements of the position of the markers relative to the tumor would be taken, as well as some imaging, including a fundus photograph and ultrasound imaging. So after the surgery comes the treatment planning phase. These surgery measurements and imaging are used to create the treatment plan. During this time, we determine the optimal gaze angle. So the patient will be asked to look at a certain place during treatment and that position is determined based on the tumor's position in the eye relative to critical structures. And at this stage, that brass patient-specific aperture is also designed and produced. So for treatment delivery, we have KV X-rays that are used to position the patient based on these radio-opaque markers. So we know where those are relative to the tumor and where they should be. So that's used for IGRT essentially. The patient gazes at that fixation target and then eye motion is monitored during treatment. So that's kind of while radiation is being delivered. So that's kind of the standard workflow that's been used for many years at passive scattering centers to treat ocular sites. So switching gears a bit to talking about the proton beam therapy program at Mayo in Rochester. So they started treating with protons in 2015. A wide variety of clinical sites are treated on 4 different gantries, and it's a Hitachi ProBeat spot scanning proton facility. So this is obviously the treatment couch here. The gantry can rotate around the patient. It's a 180-degree gantry rotation. So if you want to treat on the other side of the patient, the table is spun around. It's a synchrotron-based system capable of treating or delivering energies ranging from 71.3 MeV to 228.8 MeV. It has in-rim oblique KV imagers. So the X-ray tubes are in the ground, and then these are the imaging panels up here. So it's orthogonal X-rays. So we started treating on this system in 2015, but ocular sites were not treated due to the inability of the system to deliver a suitable beam for ocular treatments, which we'll talk about why that is in a minute. So starting to think about treating ocular patients with a spot scanning instead of a passive scattering proton beam delivery approach. So just first talking about the differences between the two beam delivery techniques. This is obviously a very elementary picture without any of the upstream components in it. But I don't really want to get into the specifics of beam delivery between the two. So just to overview briefly, passive scattering you can think of as we're treating the entire target at one time. There's scatterers upstream in the beamline, so we have a large proton field by the time it gets to the patient, and then that's shaped by a brass aperture that's milled out to the specific target that we're treating. So for spot scanning, it's a little bit different. We have a very narrow proton beam, which is magnetically scanned throughout the target volume. So we can kind of steer the beam where we want it to go. This allows us to get a little bit more conformity with our treatments. And it's kind of becoming the main modality that new proton centers are being built as. So looking to treat ocular sites at Mayo, some of the infrastructure required, we do need an aperture system. So our single spots, while they are small and allow us to have conformal dose distributions for other clinical sites, since the targets in the eye are so small on the order of a centimeter or two, we do need an additional aperture system to collimate the beam. So that needed to be developed. We also need a gaze detection and monitoring system. So somewhere for the patient to look during treatment and a way of monitoring their eye position as treatment is delivered, so delivery can be halted before or in case they look away. And then also, as with any clinical project, the development of all the clinical workflows needed to be considered. So this includes simulation, treatment planning, patient-specific QA, and treatment delivery. So kind of with this in mind moving forward, this project was formed to develop this infrastructure. It was very important for all of these ocular components to be easy to set up and not permanently modify the beamline in any way. The idea was that ideally you could treat an ocular patient in the morning, for example, and then in the very next time slot, half an hour later, be treating a non-ocular patient. So we didn't want anything like upstream, for example, or like in the gantry nozzle itself that was going to modify the beamline. It needed to be quickly reversible to treat other clinical sites. So I'll talk about the aperture system design and commissioning, which will be the bulk of this talk. Most of the work shown in this section is currently under review for publication in medical physics. So the aperture that was developed at Mayo consists of several components. It's made of acetyl and polycarbonate plastic and is mounted on this aluminum base plate, which slides directly into the gantry nozzle. So just to orient you a little bit, this part at the top, this is the gantry. So this would be like a straight down treatment. The patient couch, this is where the patient's head would be, or eye, and then in this picture, there's just a phantom there. So the whole system is mounted on this aluminum base plate, which just slides into the gantry nozzle. There's two main components. There's this intermediate scraper layer, which is tiered. The goal of this is to attenuate stray protons. And then the two different levels were done to minimize the weight of the entire device. And this is made out of that acetyl plastic. We also have the patient-specific aperture and the aperture holder, which sits 5 centimeters away from the surface of the eye. And it's difficult to see in this picture, but there's a white insert in this aperture holder, which is 3D printed, and that would be a patient-specific aperture designed for their specific shape of eye or target. So the whole system is designed to be able to treat targets to a maximum diameter of 4 centimeters and up to a depth of 6 centimeters. So to demonstrate the utility and necessity of a aperture and why we can't just treat with a single spot, these are some cross-plane film measurements of a single spot with and without a 10 millimeter diameter aperture. So without the aperture on the left, we have a full width half max of about 35 millimeters. And when we're talking about ocular targets being on the order of 10 to 20 millimeters, that's just too big. However, when we put in our 10 millimeter diameter aperture, we see that the dose is carved down nicely, and we have a full width half max of 12 millimeters. And then this picture here shows those profiles just to emphasize that the aperture is functioning. So an important thing to ensure and test was aperture alignment, making sure that it's aligned with radiation and room isocenter. So this was investigated using a in-house built alignment device that's used for other quality control within the proton beam facility. So in this picture here, we have the gantry at 90 degrees, so coming in laterally to where the patient would be. We have this device that contains a small BB at the center, which is positioned using our KV X-ray imagers to be at room isocenter. And then there's film on the distal part or the distal edge of this device. So we would have the beam coming through the aperture, hitting the BB, and then delivering on film with a single spot. So to get an idea of how well the aperture is aligned, we can measure the displacement of the center of that BB from the center of that radiation field. So I apologize, it's a little bit difficult to see with this without some color thresholding on the film. But we do have a lighter area in the center of these two films, and then this would be the proton spot. So this was done for gantry angles of 0 degrees and 90 degrees, and looking at that offset of the BB from the center of the radiation field. We see 0.3 millimeters when gantry is at 0, as well, and 0.64 millimeters when gantry is at 90. So this increased discrepancy at gantry 90 is not super surprising. That's when gravity would be affecting the aperture the most. And we will be primarily treating at gantry of 0. So this was deemed to be acceptable. And I'll just mention that since these particular measurements were done, a quick test to verify aperture alignment that can be done daily before patient treatments has been developed. So one of the most important things to assess while commissioning this system is the ability of the aperture to deliver clinically relevant dose distributions. So we want to make sure that we can deliver things that are similar enough to how passive scattered systems have delivered protons to these ocular targets. So we tested this through both Topaz Monte Carlo simulations and film measurements. So today, all the results I'm going to show were investigated for a spread out Bragg peak designed to treat from 15 millimeters to 30 millimeters depth. That was taken as representative of a typical target. And then this used energies 88.5 MeV to 100.7 MeV. I'll point out that for treating ocular sites, we do need to use a range shifter. So a range shifter is essentially just a slab of material that goes into the gantry nozzle to pull back the range. Without it, our lowest energy on this system treats to a Bragg peak depth of about 4 centimeters, which would be too deep for ocular targets. So using this range shifter is required. And then the distal fall off for the 90% to 10% levels for this Bragg peak was 2 millimeters. So in-plane profiles were evaluated in a number of ways. These were, unless otherwise stated, evaluated in the middle of the SOBP, so at 23 millimeters depth. They were normalized to 2 millimeters inside of the aperture edge. So for example, here where we have a profile with a 20 millimeter diameter aperture, the dose equals 1 at a position of 8 millimeters. That's 2 millimeters inside of the aperture edge. And we looked at a number of different parameters to evaluate the resulting dose distributions. We looked at lateral penumbra, which is the distance between the 80% and the 20% dose levels in the lateral fall-off region. I looked at central axis dose, so what kind of hotspots were being delivered along the center, giving in mind that our normalization is occurring 2 millimeters inside of the aperture edge. And then we also looked at efficiency, so evaluating absolute dose, which was defined as absolute dose at 2 millimeters inside the aperture edge divided by the number of simulated particles. So this is typically expressed throughout this as relative efficiency to compare different spot configurations, which I think will make more sense as we continue. So looking at single spot dose distributions, so just have a single spot along the central axis for treatment delivery. We did film measurements as well as Monte Carlo simulations for this scenario for that spread out break peak with a 10 millimeter diameter aperture. So we have the supinf and right-left profiles for both film and Monte Carlo shown on this figure here. We see fairly good agreement between the two, keeping in mind some noise from the film measurements, as well as limited resolution for the Monte Carlo. We determined a lateral penumbra of 1.1 millimeters and a central axis dose of 101%. In terms of the symmetry of the profiles, we had 0.4% in the right-left direction and 1.6% superior-inferior. So that increased tilt that we see with the superior-inferior profile is consistent with the direction of aperture misalignment that we looked at a few slides ago. So this was really promising. We were really excited about the agreement between film and Topaz, as well as these lateral penumbra and central axis dose values, which are similar to or comparable to the dose distributions you would get with the passive scattered proton system on a dedicated eye line. But of course, not all targets are going to be 10 millimeters in diameter. So we looked at increasing aperture size with just still having a single spot and how lateral penumbra and central axis dose were affected. So as you would expect, as we increase our aperture diameter, our central axis dose is increasing since we do have a Gaussian shaped spot. And as our aperture gets bigger, we're going further down alongside the fall off of that Gaussian. Our lateral penumbra is also getting a little bit bigger, which again makes sense with that we're going further out along the Gaussian. So in terms of clinically acceptable dose distributions, that is dependent on the physician's preferences, which you'll get a different answer depending on who you talk to, but it became very clear that beyond about 20 millimeters and arguably below that, a single spot was not going to be sufficient for those size targets. 120% plus hotspots are not going to be clinically acceptable. So to develop a planning strategy for larger targets, we introduced this 5-spot dose distribution where we have our configuration, where we still have our central spot in the center of the target, but we've also introduced these 4 corner spots. So the position of these 4 corner spots is characterized by this parameter D, which is essentially just the position offset in both the vertical and horizontal directions. And then all corner spots have that same offset. So they're equally spaced from that center spot. For weighting, was defined as the number of protons delivered from each corner spot relative to the center spot. So for example, if we had a weighting of 0.5, that means that for every proton delivered from the center spot, there's 0.5 protons delivered from the corner spot. So the spot configuration is a little bit different than how we would normally treat large targets with a spot scanning beam where we'd have a uniform kind of rectilinear grid width where we'd scan throughout the treatment volume. This configuration was introduced because we wanted to minimize the number of spots to improve delivery efficiency, reduce leakage, reduce the lateral penumbra, and also minimize the size of the aperture. We didn't want to have a lot of spots outside of the target contributing dose, since that was deemed to be a little bit wasteful. So as an example of a 5-spot dose distribution, this is for a 40 millimeter diameter aperture with our corner spots placed with a spacing of 20 millimeters and a weighting of 1.0. So again, that would mean that for every proton delivered from the center spot, 1 proton is being delivered from each corner spot. So we have a film measured dose plane of that dose distribution here. And then here are some profiles comparing between film and Monte Carlo. So again, we see really nice agreement between film and Monte Carlo results with right-left profiles shown here, and then diagonal profiles shown in this figure on the right. So it's noteworthy that because of the position of the spots, these diagonal profiles are blown out a little bit more than the right, left, or and post profiles would be. So based on that agreement with film and Topaz, we decided to move our investigations to Topaz Simulations. It's much easier to look at a wide variety of different parameters. It becomes unfeasible doing all these measurements with film. So we looked at the effects of varying corner spot spacing and weighting for a variety of different apertures to investigate the trade-offs. There's always going to be a trade-off between lateral penumbra, central axis dose, and efficiency. So these graphs here were generated for a 20 millimeter diameter aperture with possible corner spot spacings of 5, 10, and 15 millimeters. So a corner spot weighting is on the x-axis of all these plots. So just wanted to point out that a corner spot weighting of 0 would correspond to just that single spot configuration with just the single spot in the center of the field. So as we go from the single spot to the 5-spot configurations, we do see an increase in lateral penumbra, which makes sense since we are delivering protons near the aperture edge now, but that tends to stabilize as corner spot weighting increases. In terms of central axis dose, as expected, you're going to get the highest central axis dose for the single spot, and this is going to decrease as you increase both corner spot weighting and spacing. The trade-off with that, though, is that as corner spot weighting and spacing is increased, our relative efficiency is decreasing. So this is all normalized to the relative efficiency or the efficiency of a single spot for this aperture size. So ultimately, those kind of graphs that I just showed were developed for a variety of aperture sizes spanning the size of clinical targets we expect to be treating. And they were developed in order to help clinicians make trade-offs during the planning process. So as with anything in radiation therapy, there's always a trade-off. So for this case, we're trading off between lateral penumbra, central axis dose, and efficiency. So there's a number of things that clinicians would need to keep in mind when deciding on appropriate configurations. So you must always consider that, for example, increasing corner spot spacing will decrease your central axis dose, which is advantageous, but will increase your lateral penumbra, which is obviously a disadvantage. And then decreasing your central axis dose is always associated with a decrease in efficiency. And as a consequence of that, an increase in treatment time. So these trade-offs will likely be different for different clinical cases, depending on the patient, depending on the target's location relative to critical structures. So we have all of this information tabulated and these trade-offs available to help with the clinical decision-making process. So to compare to existing ocular beamlines, so kind of the conventional passive scattered systems, previous publications have reported lateral penumbra values ranging from 0.9 millimeters to 2.6 millimeters, as well as distal fall-offs ranging from 0.7 millimeters to 6.6 millimeters. So comparisons are difficult since the parameters depend on a variety of target size and depth, and that information isn't always clear in the literature. But based on the plots I showed previously, the system that we've developed is capable of delivering dose well within these ranges. So a couple other things we looked at during the design and commissioning process of the Aperture system. We verified absolute dose delivery using a pinpoint 3D ion chamber. So this table here shows our ion chamber and Monte Carlo dose measurements or dose values for both a single spot as well as with a 1 centimeter aperture, as well as a 5-spot an example 5-spot configuration with a 4 centimeter aperture. So we saw a dose agreement on the order of 1.5 to 2%. In terms of depth dose agreement, we evaluated the effect of the aperture on proton beam range. These measurements were done using a multi-layer ion chamber. So for example, here we have a central axis spot for a single energy layer without the aperture and with the aperture. So this is a depth dose curve. And then for an off-axis spot as well. So we found that the aperture did not impact the range of the protons, which was great news since the range of all of our energies had been extensively commissioned during initial commissioning of the Proton Beam Center prior to opening in 2015. So once we verified that there was no effect on it, we had confidence in those measurements applying to ocular treatments as well. We also evaluated potential leakage of the system. We don't want to we want to make sure that our aperture system is collimating the beam appropriately and not accidentally delivering a ton of dose outside, for example, to the contralateral eye. So this was evaluated by delivering about 60 gray, which would be the total prescription dose for these patients, and then placing film at locations where we're concerned about potential leakage. So on the surface of a phantom, for example, this would catch potential leakage that would occur at the contralateral eye outside of the treatment field. And then we also placed film on the aperture itself to make sure it was sufficiently attenuating. So no concerning leakage was identified. As an example, here we have our film profile for this piece of film here. This increase corresponds to this tiered aperture approach, but this dose is teeny. It's less than 0.2% of the dose that's delivered. So there is no concerns with leakage. So I'll talk a little bit about the gaze fixation and monitoring system that we developed. So this was designed and constructed by the Division of Engineering at Mayo, which a large team that consisted of everything from software to mechanical engineers. They're absolutely fantastic. So here's some pictures of various iterations of the gaze fixation system. So if we have our aperture mounted in the nozzle, the idea is that this system would kind of wrap around the aperture, and then we'd have our patient lying on the couch below that. So the system consists of a gaze fixation target, as well as an infrared light source to illuminate the pupil, and a camera for pupil tracking. So those components are able to slide around this ring. So depending on the gaze angle that is determined during planning, we can set the target or the gaze target to a reproducible position along this ring, and then set the camera in a location where we are able to visualize the eye that we're treating. So from the patient's point of view, this is what it would look like from underneath the aperture looking up. So here we have the gaze target. This is what they would be asked to look at during treatment. And then this is the camera, which is monitoring their pupil position. There is gaze tracking software that was developed that's associated with this. So this allows the pupil position to be continuously monitored during treatment and compared to a reference image. That reference image is taken during setup. So when we know that our clips are in the right position based on X-ray image alignment, that's when that reference image would be acquired. And then during treatment, this is monitored, and then the beam is stopped if a pupil movement tolerance is exceeded. And then this whole system was designed to kind of have a similar interface and functionality to the existing respiratory gating software used at the Proton Center, just for staff ease of use and familiarity. So to wrap up with some discussion and final thoughts, so Mayo is not the first center to look at treating ocular targets on a spot scanning proton system. A number of centers have been doing this work concurrently. The Italian National Center for Oncological Hadron Therapy developed a system using a brass aperture and a general purpose horizontal beamline. So they published this work in 2019. Their aperture would be at this position F, and that's a brass milled collimator. So a little bit difficult to see in this picture, but you can get the general idea of this setup. Similarly, the University of Washington has recently published on their system, which also uses a brass aperture. You can see, so this is the aperture, again, milled out to the patient-specific shape, coming in close to the patient eye. And then they're treating with a fixed horizontal beamline. Just wanted to point out that another McGill alumni worked on this project. Allison Toltz is a co-author on this publication. So kind of coincidental that we both ended up working on ocular proton beam projects during residency. Some unique aspects of the Mayo Clinic system compared to these systems. The main difference is that our entire system is made out of plastic. So there's no brass involved. This has several advantages. It doesn't become activated. Easy handling, it's quite light, easy for one person to mount it on the gantry, can be done in a matter of seconds. It also allows transmission of KV X-rays, so they can be transmitted through the aperture system, so we can still visualize the clips, which helps with the setup. So we have our 3D printed as patient-specific aperture, as opposed to the brass one that's done at other sites. So this was useful for us. We didn't have brass milling capabilities since we don't treat other clinical sites with apertures, but we did have 3D printing capabilities already in place at Mayo. So this might be a useful consideration for other institutions who are in a similar position. Also, our aperture is compatible with the gantry system as opposed to the horizontal beamline demonstrated at other centers. So this allows us to treat patients supine the same way we would treat other clinical sites on our Proton system, which also eliminates the need to commission a dedicated treatment chair. We can just use our existing couch, which has already been very well characterized. So some final thoughts. So the ocular infrastructure developed at Mayo allows for ocular patients to be treated on the same gantries as non-ocular patients with minimal changes to the beamline. The whole system can be set up in a matter of minutes, including the gaze tracking system as well as the aperture. This approach could be adopted by other institutions without a dedicated eye line to treat ocular patients. And then the goal is that this work will ultimately result in expanded access to proton therapy for ocular proton patients. As of, I believe it was around 2015-ish, a survey by the Ocular Proton group came out, and there were only about 15 sites worldwide treating ocular patients with protons. So hopefully this can expand access and provide this treatment option for more patients. So thank you very much. Feel free to reach out. My email is here, and I'd be happy to take any questions.